So, what are the clinical signs of the subchondral cystic lesion? So, you see lameness because you have pain in the joint, synovitis. You also have a subchondral bone, which increases in intraosseous pressure, so pressure inside the bone. Like, remember that hydraulic theory I mentioned? Lameness can be either mild to severe, and the onset can be insidious, presentation of lameness to fairly acute. You can do flexion tests to sort of see what's going on, and it sort of aggravates the lameness. And with these lesions, subchondral cystic lesions, I'm just going to keep calling them lesions. They're usually associated with distension of the joints. So I think they get larger. And lameness usually improves with inarticular general anesthesia. So this is a way of diagnosis. So yeah, this is usually in one horse is 1 to 3 years old. And when the joint communicates with the lesion. Oh, okay, never mind. Anyway, so in terms of diagnosis, you can use X-ray. So it says round to oval subchondral lucency with a variable surrounding sclerotic rim. That's what this means. So this is a round to oval shape. You can see subchondral lucency, meaning it's a little see-through, and it has a sclerotic rim. Same here. And yeah, this shows you just some lesions. So this is the distal radius. Yeah, it's kind of obvious in the coffin bone, and yeah, distal metacarpal condyle. So yeah, we can treat it by rest, of course, NSAIDs, vitamin supplements, anabolic drugs, but the failure rate is pretty high, so I don't know if it's a good idea, but yeah, NSAIDs reduce inflammation. You can limit exercise and give intra-articular steroids like hyaluronan. So apparently this is better. So if they ask, yeah, I would say exercise and steroids for this to treat the lesions. Benzopyron, has been used in horses. They've been seen returning to normal. And that's assuming the pain that they're experiencing and lameness is associated with these lesions. But yeah, these lesions lead to increased intraosseous pressure, so this drug should decrease that pressure. There's also bisphosphonates that inhibit the bone resorption by osteoclasts, those cells I mentioned. So they reduce the number and reduce the activity by causing apoptosis. One example is osphos. And surgical treatment, you can do debridement, so this is basically removal using an intra-articular approach with an arthroscope or a transcortical approach. So you have grafting procedures, which are pretty after debridement. So you remove something and then you replace it with something else. So you remove the lesions, you replace them with something else. So you pack the lesion with autogenous cancellous bone grafts, so basically other bones. And you can use tricalcium phosphate granules as filling material, and you fill the lesions also with parathyroid hormone and a fibrin hydrogel. We must know that this is related to calcium regulation, and it also says bone morphogenetic protein, so BMP. It's a member, and it's made by osteoblasts, so we can also use this to induce basically osteogenesis. Next we have this disease, phthisitis and physiodysplasia. So what it is these are bone diseases in young, rapidly growing horses with enlarged growth plates of certain long bones. Let's pretend like the tibia or femur, for example. And basically, they're enlarged because of inflammation, disturbance in the structure. Maybe the ossification is out of sync, and you can get limb deformities. This is usually occurring at 4 to 8 months of age, up to 2 years, especially in thoroughbreds and crosses of these breeds. And it may affect not just one growth plate, but several. It can also occur in both legs at the same time. There's obviously genetic predisposition because thoroughbreds were mentioned, and yeah, it's usually with intense feeding regime. So let me see the etiologies. Okay, so there's septic phthisitis. So basically, it's because of an infection in the long bone, and it can extend into the joint capsule. Examples include Streptococcus, Rhodococcus, Actinobacillus, Enterobacteriaceae. So anything like E. coli, the cocci, and Actinobacillus. Trauma. So for example, Salter-Harris fracture type 5 with excessive compression or microfractures and disturbed ossification in the affected regions. So these tiny fractures cause inflammation, stimulate bone production, and secondary bone disorders occur more with trauma-induced fasciitis. Now, with these developmental diseases, obviously they're associated with genes and nutrition, so these primary disorders can lead to trauma-induced fasciitis, or there's a form of osteochondritis dissecans as well. So issues with ossification of the cartilage in the physical growth cartilage. So this usually occurs in the distal third, metacarpal or metatarsal areas, distal radius, tibia, and less in the ends of the femur or the vertebral bodies. You'll see, let's say, they'll walk quite stiffly, they'll appear to be lame, as I mentioned. You'll see swellings on the physial areas with increased heat, so the ends of bones, long bones, and you'll see flaring predominantly medially. There's something called concomitant valgus, so if the medial physical area is affected, or varus if the lateral physius area was affected. So the legs will move out or in. So it's not always necessarily, congenital. Could be this, although this can be congenital as well. You also have an hourglass shape of the fetlock, so kind of like this, if the proximal phalangeal fissure was affected with the distal metacarpal metatarsal area. So I mentioned clinical signs. I think I'll say this and then I'll stop when we get to x-rays. So clinical signs, so we mentioned the hourglass appearance of the fetlock joint, so you can see it kind of is in, out, in. Think Marilyn Monroe's waist. So fasciitis of the distal aspect of the cannon involves usually for all four legs. And basically usually the ends, so the distal parts of the radius and tibia, are usually not involved together, and falls with metacarpal metatarsal fasciitis can also have this in other locations, and this is related to the activity of the physes with respect to bone growth as well at varying ages. So we'll stop here.